Abraham sir, good morning. Good morning. Today we are having our audit presentation of MR Bangalore Hospital. We have 3 units running in MR Bangalore Hospital. We do OPD on twice a week, and we have OT days on twice a week. So audit is a part of a DNB teaching program, because DMA board expect that every hospital running DNB program should have their monthly audit being done. And the audit is a review of what you have done over the period of last 1 month. And the idea of audit presentation is to review what sort of work we are doing, what is the outcome, and at the end we discuss something so that we can find out whether you would have done anything differently. So that is the idea of audit presentation. And I would expect other institutions in West Bengal, they also will have their own audit being done every month, so that they can review what is being done over a period of month. Today we have audit for 3 units. The first unit will be Dr. Shumon Pal. He will present the audit. Shumon, you can share your screen and present.
Good morning, sir. A very good wish for the season of light to everyone, and pranam to my seniors. I am Shumon Pal. Sir, am I audible?
Yes, very much.
I am Shumon Pal from Unit 1 General Surgery of MR Bangalore Hospital. I'm going to present the surgical audit for September 22. As a whole, we have faced in total 10 admission days in that month, out of which 8 were OPD days, and total patients we have seen were almost about 1,314, out of which 580 were old patients and 734 were the new one. No COVID-19 patient were found. Total elective OT days, we have faced 8, out of which almost about 26 hours and 40 minutes we have spent in laparoscopic interventions, that is in table 1. And in open interventions, we have spent 20 hours, 40 minutes, almost about. Total minor OT days were 9 in number. We were a bit lucky that mortalities were 0. And in the minor OT, we have spent 19 hours, 45 minutes. And emergency OTs, we have spent almost about 10 hours. Sorry, there is a writing mistake. That is for September 2022. Total number of elective admission were almost 35, out of which 21 were male patients and 14 were female. Emergency admission were through the emergency itself, and total 23 number, out of which 11 were male patients and 12 were female patients. Elective operations, we have done almost about 30, out of which 19 were male and 11 female patients. Emergency operations, we have done 7 in number. Minor operations were 35, and 0 mortality and morbidity itself. Next slide, please. Now coming to the elective admission, as far as the hepatobiliary system and pancreatic and splenic surgeries are concerned, we have done chronic calculus, laparoscopic cholecystectomy, where the chronic calculus cholecystitis, where the diagnosis almost about 8 in number, out of which 3 were male patients and 5 were female patients. As far as GIT and perianal cases were concerned, like fistulectomy, we have done in fistula in ano, where total 1 in number. It was a male patient. And fissure in ano, lateral sphincterotomy was done in that case, and it was also 1 in number. Recurrent appendicitis, where we have done laparoscopic appendectomy, where 3 in number, out of which 2 were male patients and 1 was female one. 1 patient was suffering from recurrent appendicitis, where we operated open appendectomy. We went for open appendectomy, and it was a male patient. Liechtenstein tension-free mesh hernioplasty was done in inguinal hernia cases, which were totally 3 in number, and one total thyroidectomy with lymph node dissection was done in thyroid cystic swelling with papillary carcinoma, only in one case, and that was a female patient. And in miscellaneous, we have operated, we did circumcision in a case of phimosis. Now, as far as emergency operations are concerned, we did one exploratory laparotomy with excision of affected part, followed by terminal conostomy and closure of distal segment in a case of sigmoid volvulus. It was a male patient, and he was admitted through the emergency. Also, in acute appendicitis, we did open appendectomy in 2 cases, and incision drainage was done in perianal abscesses. They were 2 in number. Diabetic foot ulcer often comes to our emergency, and we have found 1 male and 1 female patient in September month, and those were debrided and dressing was done accordingly. Now, as far as minor operations were concerned, wedge biopsy from ulcerative lesion were 1 in number. Few excision of sebaceous cyst were done. Those were 6 in number. Lipoma excision, Zadek procedure, and incision and drainage of abscess, and foreign body exploration was done. Altogether, they were 26 in number. These were minor operations. Thank you, sir. There were no mortality and morbidity in the last month. We were a bit lucky. Thank you.
Okay, Shuman, as I said earlier also, when you think of morbidity, so you have operated 26 minor operations, you have 7 emergency operations, you have 30 elective operations. So morbidity, I mean that any deviation from the normal recovery is taken as morbidity. A minor wound infections, a prolonged paralytic ileus. So any deviation. So that you have to record day to day. So at the end of the month, I agree that you're presenting that you have no morbidity. But what I'm trying to say is you should vigil each of the patient and record in the register daily whether the patient has got any complication in the post-op period. That is the idea of presenting, and you need to discuss why the patient deviated, what you have done to alleviate that particular situation. So mobility should be taken care of. It's very unusual if my 3 units say at the end of day today that none of them has any morbidity. It is difficult to accept. There are some patients who behave different in the post-op period. Some may have prolonged ileus, some may post-op some complications. So that is the idea of morbidity. I mean that. Okay, it's not a major morbidity. Even a minor morbidity, like to discuss. What is happening in our situation? Are we having more infections? So if it is true, then we should take some measures to reduce that. Okay, so keep in mind that one should keep in vigil any morbidity.
Okay, sir.
Okay. So the next presentation will be by Dr. Prashanjit Basu, is a first year junior resident at MR Bangur Hospital. So Prashanjit will present surgical rate for Unit 2.
Good morning, our respected faculty members and our seniors. I am Prashanjit Basu, going to present surgical audit for September month under Unit 2 General Surgery, MR Bangur District Hospital.
Prashanjit, you are not audible.
Some
Dr. Prasanjit, you're not audible. Can you please check your audio connection? Dr. Prasanjit, please unmute yourself.
hello. Total OPD days 9. Total admission days includes 10. Total patient with COVID-19 infection 1. Total OPD patient 1125, which includes old 450 and new 675. Total number of elective OT days 9. Total time in OT lab includes 37 hours and 30 minutes and open 52 hours and 30 minutes. Total number of minor OT days 9. Total number of mortality 1. Which includes elective admission total 68, 29 male and 39 female. Emergency admission includes 18, which includes male 8 and female 10. Elective operation 42, 16 male and 26 female. Emergency operation 7, which includes male 3 and female 4. Mortality and morbidity has both single cases. In elective admission, we are going to operate a hepatobiliary and pancreatic splenic surgery, chronic calculus cholecystitis, which we done laparoscopic cholecystectomy in 17 cases, in which 4 are male and 13 are female. And in 2 cases, we did open cholecystectomy in female cases. In GIT and perianal cases, we did we include fistula in which we did fistulectomy, which 3 males and 1 female. In fissure in ano, we did lateral internal in sphincterotomy, 1 single female case. In hernia and groin surgery, incisional ventral hernia, we did mesh hernioplasty at retrorectus plane in a single female case. In inguinal hernia, we did Lichtenstein tension-free mesh hernioplasty, which includes 6 male and 1 female hernia case, inguinal hernia. And in 2 cases, we did herniorrhaphy.
Dr. Prasanjit, your audio is not there. Please correct your audio.
For breast and endocrine cases, a single case fibroadenoma for which we get the local excision of fibroadenoma of breast. In miscellaneous cases, we did excision of lipoma in single case and single varicose vein case for which we get saphenous vein plus ligation with stripping of saphenous vein. And a case of chronic pancreatic cholecystitis is presented, chronic pancreatitis, calculus pancreatitis for which we did lateral pancreaticojejunostomy in a case of chronic calculus pancreatitis. In emergency cases, we did admitted acute appendicitis, diabetic ulcer, and peptic ulcer perforation, for which we did open appendicectomy, and for diabetic ulcer, we did diabetic debridement, and for peptic ulcer perforation, 2 cases were admitted. Both were male cases, and ground patch repair done in both the cases. Minor operation, we did excision of hemangioma, 1 case, the excision of pyogenic granuloma, 5 cases, in which 3 are male and 2 are female. Lipoma excision, total 7 cases done, in which 3 are male and 4 are female. Nail avulsion in a case of ingoing toenail paronychia, in which total 5 cases we did, 2 were male and 3 were female. In sebaceous cyst excision, total 9 cases were done, in which 4 were male and 5 were female. Morbidity includes 2 cases in which we did exploratory laparotomy and peptic perforation repair. It were presented with wound infection and localized collection at surgical site, for which we did a regular dressing, and later on we did secondary suturing for that. Mortality, single, by mistake it is a female case, I did miss. A 68-year-old female patient is admitted with the features of huge anterior abdominal mass, which later diagnosed as anterior parietal wall hernia with ascites, with bilateral pleural effusion with ischemic heart disease with COPD. This patient was admitted from emergency. The patient is on severe septic shock with multi-organ dysfunction syndrome. We managed conservative and later plan for mesh hernia plus PVN. Patient became hemodynamically stable, but later patient developed sudden cardiac arrest and could not be resuscitated. And thank you.
Prashanjit,
Yes, sir.
what was the time interval between the patient got admitted, patient outside resuscitation, and patient death?
Sir, it 1 to 2 days, sir.
1 to 2 days.
Yes, sir.
So is it a possibility that patient has got a strangulated hernia?
Maybe, sir. Maybe. But sir, there is no.
You did a CT scan in this patient?
Yes, sir. CT scan. Hello.
Yes, CT scan.
CT scan does not reveal any signs of CT for this patient, but there is no sign of strangulation or obstruction.
Okay.
CT scan commented that the content of the heart is bowel, but there is no comment on strangulation or obstruction.
Okay. The lateral pancreaticojejunostomy for chronic pancreatitis, is it just LPJ? Is it only LPJ, or you did a head coring also?
No, sir, head coring is not done. Only LPJ. Drainage procedure.
Is your bed in charge there, Dr. Abhishek or Dr. Joydeep Rai? They are online?
No, sir.
The point is, at present, the standard of care for chronic pancreatitis is just not the LPJ. One should add a head coring, a fresh procedure that provides a longer period of pain-free interval, because the pacemaker of pain in chronic pancreatitis is in the head. So one should do a additional head coring along with LPJ. I don't know why you have not done this in this patient.
Head coring is not done. Okay.
So for the mortality, give little more details. The patient admission day, what was done next, what is the next day, and then what happened over the period of days, so that you can analyze why the patient died, whether you could have done something differently to avoid this death. Okay.
Yes.
Dr. Abraham, I can find you online. Any comment regarding the presentation by the student? Okay, we pass on to the next presentation by Dr. Diptaman, who will be presenting the surgical audit of Unit 3. Diptaman, please share screen and present.
Sorry, sir, I was muted. I'm sorry.
Yes, sir.
The mortality of inguinal.
Yes, sir.
Was there a strangulation? Whether we have done the surgery a little early to avoid sepsis and sepsis-induced issues? All those things could have been discussed.
Yes, sir. Because they said the patient died within 2 days after admission. They started resuscitation, and then.
Well, the presentation was 1 to 2 days, which is 24 to 48 hours. They have to be very specific regarding what all events have gone through. Whether the patient 24 hours time is considered generally included as a criteria for anesthetic issues. Beyond 24 hours, then it becomes the burden on the surgeons, unless until there is a documented hemodynamic insult, myocardial infarction, or a PE or anything of that kind.
Yes,
so
sir.
I think it would have been fairer if they have analyzed the situation a little more. As you said, this is not a finding the fault issue.
Yeah.
It is a technique by which we retrospect ourselves and try to improve on our thought process. So that's what I would think the end result.
Yes,
Thank
sir.
you,
That is
sir.
the idea. Yeah. I
Thank
told
you.
them to give little more in-depth analysis.
Yeah, I heard, sir. I said I was
we are not
muted,
doing
but I was
post-mortem,
hearing.
but short of that, we can do something at least to analyze.
Yes, sir.
So next is Dr. Diptaman, who will present surgical audit for Unit 3 of MR Bangur Hospital. Diptaman, please.
Yes. Good morning, with my respected teachers, my dear colleagues, and my respected teachers. First of all, I wish a very happy Diwali to everyone.
Diptaman, your audio is not very clear. Just try to improve. Come closer.
I am going to present the surgical audit for September. I'm going to present the surgical audit for September 2022 under Unit 3 General Section. Next, please. Now, in the month of September, number of OTGs of our unit was 8, total admission days were 9, and total number of OTGs were 1104. Next slide. Total number of OT days was 8. Total time spent in OT was 47 hours 20 minutes. Total number of minor days 19. Total number of mortalities were 2, and total number of morbidities were 3. Now, little detailed description regarding this audit of September 2022. Elective admission in our unit was total 42, which included 23 males and 19 females. Emergency admission was 4, which included 3 males and 1 female patient. Elective operation done was 31, which included 13 males and 18 females. Emergency operation done was 3. All these 3 were male patients. Mortality was 2, which included 1 male and 1 female. And morbidity was 3, which included 2 male and 1 female. Some detailing regarding elective admission cases. Chronic cholecystitis cases was total 7, included 1 male and 6 female who underwent laparoscopic cholecystectomy. Chronic calculous cholecystitis cases were and 2 was managed with open cholecystectomy. These 2 were female patients. Inguinal hernia cases were 2, which were male patients who underwent laparoscopic hernioplasty. Then there were another 2 cases of inguinal hernia of total 5 patients, included 3 male and 3 female cases who underwent open hernioplasty. Then there were 2 cases of perianal fistula who underwent fistulectomy operations. These were 2 male patients. Obstructive jaundice case was 1 who was managed with laparoscopic CBD exploration with T-tube drainage. This is the male patient. No, I'm sorry, this is the female patient with the printing error. Then there is a case of diabetic foot ulcer who underwent debridement. Elective admission is detailed further. Pancreatic cytosis case was 1. This is a female patient who underwent cystogastrectomy. Then there was a post-spirally stricture patient, male patient, who was initially done feeding gastrojejunostomy. Now he underwent gastrojejunostomy. Then there was one anal fissure case who underwent lateral anal sphincterotomy. This was a female patient. Recurrent appendicitis case was 1 who underwent laparoscopic appendicectomy. Another recurrent appendicitis cases were total 4 in number who underwent open appendicectomy. Among the 4 cases, 2 were male and 2 were female. Incisional hernia cases were 2. These are 2 female patients who underwent open hernioplasty. Then there was one case of ischemic lining of left toe who underwent disarticulation. This was a male patient. Phimosis case was 1 who underwent circumcision, and there were 2 cellulitis cases, including 1 male and 1 female, who underwent conservative management. Further continuation of selective admissions. Multiple jejunal polyp case was 1 who underwent diagnostic laparoscopy. Achalasia cardia case was 1 who underwent laparoscopy Heller's myotomy with fundal plication. Then there was gangrenous fissure of the right leg. This type was of 2 cases were male patients who underwent debridement. There was a male patient of right inguinal abscess who underwent incisional and drainage. Varicose vein case was 1 who underwent stripping with phlebectomy. This was a male patient. Then there was one parotid abscess case, which was a male patient also who underwent IND. Now there are some emergency admission cases which can be listed as follows. Septic perforation was 1 case who underwent Graham's repair. This was done in emergency OT. Another was acute appendicitis cases. There were 2 cases which were done in emergency interventions. Urinary colitis case was 1 which was managed conservatively. And acute cholecystitis cases were 3, including 2 male and 1 female cases, which were managed conservatively. There were 1 case of scrotal infection who underwent debridement. These are the list of minor operations done in emergency OTs in the ground floor and also in our 8th floor fatigue OTs. This includes some injectional polydocanone, which were total 3 cases, including 3 males only. Excision of suspicious cyst. These were 14 in number, including 8 male and 6 females. Nail extraction cases were 8, which included 3 males and 5 females. There are some incision and drainage cases, which included 4 males, which were 4 in number, including 2 males and 2 females. There are some granuloma incision cases, including 2 females and 1 male, and injection penacot are given in total 5 patients, including 3 females and 2 males. Regarding morbidity and mortality, we had morbidity of total 3 number, including 2 male and 1 female. And unfortunately, we have 2 mortality, including 1 male and 1 female. morbidity cases are mainly related to wound infections, which were managed with regular basis and other conservative managed like IV antibiotics and these things. But next slide, please. Regarding mortality, there was a young adult male patient admitted in our ward with carcinoma colon. We are planning for elective operation in this case, but he suddenly developed one night severe convulsions, and then he became comatose and ultimately died before we can do any serious intervention. He had sudden cardiac death, and this is a very unfortunate from our part also. The mortality case number 2, this was an old female patient with ventral hernia, who also had some long-term comorbidities like diabetes, COPD, hypertension. She had a hernioplasty operation, but later she developed severe respiratory distress, septicemia, electrolyte imbalance, and unstable breathing. She was treated to CCU. There she stayed for some days. She was given all type of conservative management and regular supportive care and monitoring. But she cannot be revived, and she finally succumbed. Thank you to everyone.
Okay, thank you, Diptaman. But as I said, we are trying to understand the background behind the patient death. So, it's the mortality, these few 2 lines are not enough. We want to analyze the background of the patient. What is the course of the patient following admission in the hospital over days, and what all was done for this patient and how the patient died. So this is not the analysis of the mortality patient. It should be little more elaborate and try to find out some underlying immediate cause of death and what was exactly done. These 2 lines does not explain the turn of events which leads to death. And you are not very clear about the operative steps also. In Hiller's operation, what was done? You said fundoplication. That is not enough. There are different types of fundoplication. In this patient, we have done Hiller's cardiomyotomy with 2-pay fundoplication. That was 270-degree fundoplication. So make it very clear what was done. Okay. And then about the varicose vein. Varicose vein, it is not phlebectomy only. It was Trendelenburg operation plus stripping and ligation of few perforators in the leg and additional phlebectomy. That is the operation. Try to give a complete description of the operation. Okay. So next time you try to find out the better way of writing the things and follow the same pattern. You are not writing the every point of what other people have presented. Okay. So make it more exhaustive and better presentation. Any comments, sir?
Sir, again, the ventral hernia, that is something that worries me. There are a few things. One is, was a PFT done prior to that, whether the patient has been respiratory-wise optimized, what the euglycemic stage achieved. Prior to surgery, what was that, disease as a result of what? Is it just a wound infection? Is it a mesh infection? What has been done to that? What was the duration of the whole sepsis and why the sepsis could not be controlled? Or was it more towards a respiratory type 2 respiratory failure? Was the patient ventilated? So a lot of things could have been analyzed. That's my personal. And what is the duration of the whole treatment inside the hospital? A lot of things could have come out on that. It's not again, it's not all of us will lose patience, but the next patient, whether we can save or not is the question that, we need to learn from each mortality. Yeah, thank you.
Yes, sir. That I'm trying to emphasize for our DNB residents, that you be vigilant about the patient. Try, you say we have about 100 operations being done in the month, and they are trying to say that you have no morbidity, only 2 in infection. I don't agree. If you're operating, you will likely to have some complications. You manage that patient. All patient does not behave that way. So what I'm trying to emphasize to these residents are, you try to keep on notes. All patient does not behave. We have about 30 lab coli. So 30 lab coli patient may not behave in the same pattern. Somebody might have prolonged biliary leak. Somebody might have some other problems. So I'm trying to emphasize that part. They should be vigilant to find out what is going wrong and what is being done for that. That is our lesson. That is a lesson for the resident to learn.
Yeah, we also learn, sir, every day, because a patient who is unhappy and spending more time in the hospital is always a burden to us.
Yes, sir.
And, even a wound infection, you need to, kind of do something, start a new antibiotic, and that drains the patient. And private hospitals, we should be money conscious also, because, they are spending from their pocket, or somebody else is funding through insurance or some other agency. At least, at the end of the day, there is a financial drain, whether it's directly or indirectly. We should be accountable for all those things.
Yeah. In fact, what I'm trying to tell our residents is, we have a very good patient load. They have plenty of things to learn from these patients.
Exactly.
And we have, actually, this was a hospital which was totally COVID. The whole admission was closed for 2 years. And then after COVID, it is starting to pick up the patients. So they have to see the details, and they have to be more vigilant about this patient outcome. That I'm trying to emphasize.
Yeah.
Thank you, sir, for joining.
Thank you, sir.
You very much.
Thank you. Yes, sir. Thank you.
Thank you, sir. Okay, Milind. Tomorrow morning we will have the class on right hemicolectomy. I have talked with the Diptaman. Although tomorrow is being declared a holiday, but still we will.
Okay, sir.
9 we have the class.
Okay, sir. Yes,
Thank you.
Thank you, sir.
Sir. Thank you.
Thank you, sir.